Let me introduce now another topic I think is quite interesting. When we are talking about CAR T cell, we hear from Persis the successful story of the CAR T cell. However, I'm going to talk about pediatric cancers are not one single cancer. There are multiple types of cancer, more than 100 histological and genetic cancers. Leukemia is only 1/3 of the tumor that our kids have. And it's a successful story from the beginning until now. We are now curing more than 90% of the kids. Hopefully in the next decade, we are going to cure 100% of them. This is our dream. However, the history for solid tumors are not as successful as for leukemia. Let me introduce the topic of sarcoma. Sarcoma is, I don't know if you ever hear this word, but sarcoma is a very heterogeneous group of cancer in kids that they are extremely aggressive, and we don't really know how to treat. We are treating this cancer how we treat in the past. So we and other groups are trying to do different approach in order to improve survival and to give more chance to cure. So these are going to be the 5 topics I want to discuss with you: sarcoma in children and adolescents. Don't forget that adolescents are also our kids. NK cells and sarcoma cells, how is the crosstalk between these cells? I'm going to introduce you our sarcoma trial. It's a trial we have running in Madrid. Because we know the limitation of the NK cells, we are trying to do another approach to express a receptor of the NK cells in a T cells. It's what we call a CAR-NK approach. As Perez is explaining, CAR T cells is a T body approach or a T B cell approach. We express an antibody in a T cells. What we are trying to do with our CAR-NK cells is to express a NK cell receptor on a T cells. It's a different approach, and we're going to explain you the preliminary data of our study. But we already know that although we are doing this improvement on CAR T cells immunotherapy, we still cannot cure most of our patients. We still need more research and to improve our immunotherapies. So with our sarcomas, sarcomas is the oldest known cancer type in history. It was discovered in the ancients. There are reports from the Egyptian era that is a sarcoma of the bones. It's a mesenchymal cells that they are in the muscles, that they are in the joints, that they are in the bones, and they proliferate. It's a very pediatric typical tumor. One of the difference between adults and kids is the adults have epidermal tumors, carcinomas, and kids they don't have really most carcinomas, they have more sarcomas. So it's very typical from kids and adolescents. And what is most important after solid tumors, after CNS tumors, is the second most frequent tumor in kids. But we know all the tumor in kids are rare. In the UK, as you can see in this slide, is the third most frequent tumor in the kids and adolescents. It's a heterogeneous group of tumors. We call rhabdomyosarcoma, Ewing sarcoma, bone sarcoma, osteosarcoma, undifferentiated sarcoma, adult type sarcoma. There are plenty of tumors now that we are describing, so it's very rare. And the treatment is, we cut it, we do surgery. It's the best treatment that we can do. Just give some chemo, radiotherapy, that's all. And we have not improved the treatment in the last decades. What we are doing now is we are doing just a neoadjuvant chemotherapy upfront, just to make the tumor smaller, to give the chance to the surgery to cut it and to remove it. And then we give another cycle of chemo, what we call adjuvant chemotherapy, to try to consolidate the response. However, with this approach, is the standard of care so far worldwide, we still have not cured most of our kids. We are only about 65% of overall survival in our kids, so we need different approach. And we are doing research in different approach. We are doing molecular targeting. We are trying to identify which drive the tumor cells and try to target with some drugs, but so far they are unsuccessful as well. And also we are trying to find immunotherapy antibodies, cells that help us to control refractory or metastatic disease. So, but as you can see, this is a Kaplan-Meier slide or curve. You can see that most of our kids, when the disease is not localized, when it's systemic, the survival is suboptimal. We are curing less than 50% of our patients. They are metastatic. Doctors, when we cannot cure something, we can say, okay, if with chemo is not enough, let's give more chemo, more high-intensity chemo. So this is not the way. When we do that, it's what we call intensification or high-dose chemotherapy. This is not increase the survival rate. In fact, we increase the transplant-related mortality or the chemotherapy in transplant mortality. But when we focus in this new era of personalized medicine, try to target the driver of the fusion gene that makes the sarcoma cell, so far, most of the tumor, we haven't found nothing. Only fibrous sarcoma, we found just a a mutation that can drive up. But most of the tumor, we cannot do nothing. So what can we do to improve our survival in our patient when they relapse and when they are metastatic suffering sarcoma? So, because the successful story of the leukemia, we try to move the field also to the solid tumor, but it's more complicated. It's much more complicated because we don't have good targets. Tumor cells in sarcoma are not similar. They are very heterogeneous, most of them. Solid tumor is not as blood tumor that is like an organ. The microenvironment, the tissue is more difficult to allow the cells, the immune cells, going. And it's something that we call that most of the sarcoma tumor are cold tumor. They are not hot. They are cold because the immune system cannot go inside. So how can we make a cold tumor? How can we make it hot, or how can we put cells into the tumor? So let me explain you what is NK cells. NK cell has 50 years old of history. It's NK cell is a cell for the immune system. We divide it academically. We divide it innate immune system and adaptive immune system. NK cells come from the innate immune system. So they work very fast. They don't need to present anything very specific as a T cell need, and it's the first defense that the human being have to defend against infections, against tumor, against senescence. So when we look at how there is the crosstalk between tumor cells and the NK cells, we know that in the middle, in the synapses, there is a crosstalk between some inhibitory receptor and activating receptor. Well, one of these activating receptor is what we call NKG2D, is an activating receptor that is able to recognize not only the tumor of the sarcoma cells, but is also able to recognize the initiating sarcoma cells. The initiating sarcoma cells is the responsible of the relapse of the sarcoma cell. Most of the chemo, most of the radiotherapy is able to eliminate the sarcoma cell, but is not able to eliminate the initiating sarcoma cells. So in this work that we did in Madrid, we were able to recognize that this sarcoma initiating cell, when we isolate it in green and we put the NK cell, we are able to eliminate the culture in the slide. And when we block the NKG2D with an antibody, the tumor cells come back again. So this is a proof of concept that NKG2D is mainly immunosurveillance receptor that can control the immune response against the sarcoma cells. And when we move on to mice models in order to try how in vivo can this NKG2D receptor work, we were able to see that it's not only able to control the local tumor, but also some lung metastases are able to going back. We are always able to cure the lung metastases in the mice. So this is amazing because it's something that is not easy to show. And with this proof of concept in this different trial we did in the 2017, 2019, we hypothesize if we can use a type of NK cell that they are able to overexpress NKG2D to control this initiating sarcoma cells. So how can we obtain this NK cell from a healthy donor? How can we expand this and activate it in a GMP facility? And how can we later on, we can put again into the patient? So this is the trial we call sarcoma. It's a game of words, sarcoma. So this is very easy to explain now, but it takes, in Spain, I don't know here, Persis, but in Spain, to run a trial like this, it takes close 10 years since we started and we published the first paper. It takes a long time. It's a very difficult. It's academic. We need a lot of support. It's not easy to get funding of this trial in kids, but at the end, we are able to expand this NK cell with feeder cells. We were able to run just a phase 1 trial just to see how these cells are able to expand into the patient. So this is what we are doing. We are doing just a lymphodepleting regimen to allow these NK cells to expand. As I said before, it is allogenic. We obtain the cells from the father, from the mother. It's haplo NK cells, and then we put some IL-2 to try to maintain the response of the NK cells into the patient. So just let me show you some slides. I think this is not a medical auditorium, but just to show you how this, you can see how big are the metastases in the lung, and you can see after the treatment how we are able to reduce the tumor site into our patient. This is a very, all the patients that start in this phase 1 trial, they are refractory, they have advanced disease. Most of them, they are in palliative care. So we have to try to do our best to control the symptoms, but also to do this research on them. But most of them, we are able to find some remission in some of our patients. Not easy, very easy. But, most of our patients relapse after that. So we were able to obtain some remission in many of patients. I can show you the data later, but most of them, they relapse after that. So one of the things that happened with the limitation of the NK cells is that NK cells, I said always in Spain, like a joke, is like Dory. I don't know if you know Finding Nemo, the film for kids. Dory is a fish that she forget everything very, very fast. So NK cells act very, very active, but they forget that they have to do it again. So how can we do memory, or how can we make more? So this is why we try to do memory properties to innate cells. So this is why we think, why not combine a T cell that have memory properties with a NK cell receptor. So this is the two worlds, the best of the two worlds. We combine the best of the two worlds in a engineering receptor. So we were able to, just by gene strategy, where a ligase activity, we remove the CD19 constructor and we put the gene of the NKG2D. So we were able to have a second generation 4-1BB CAR T cell expressing NKG2D in our model. So exactly the same. We use allogenic CAR T cell, but not very fancy gene editing, just memory, 45RA negative memory, because they have less chance to induce any harmful into the patients. They do not induce GVHD because they are very, very the proliferation chance are less, so they are less alloreactivity than naive cells. So we combine these cells, these 45RA memory cells, with a NKG2D receptor on that. So this is what we try to do is this killing keys. This is the synapses, what we call the killing keys. En español, el beso de la muerte. It's more nice, it's more powerful, the killing keys. Try to improve this immune response against sarcoma. So in this video, you can see how this works. These are sarcoma cells in the culture, and you can see how CAR T cells, these are doing these bubbles into the cultures, and they are reproducing, and they are expanding each other, something that the NK cell cannot do. So this is a proof of concept in vitro, how just starting with very low dose of CAR T cells expressing NKG2D are able to recognize all these cells. But this is not the only thing important, because this is very easy to us. I mean, you put all the cells in contact. They do not have to find each other. But what we did in this experiment is try to show how the red cells are the CAR T cell, are able to go into, I think it doesn't work. Yeah, it works. But the red cells can go into the green cell. They are not only in the surface, they can go into the tumor cell. So they can penetrate, and can penetrate. It means they can make a cold tumor, they can become a hot tumor. So then we move to an in vivo model as well. In vivo model, it's very difficult to do an in vivo humanized in vivo model to prove our hypothesis, but in this case, it was a xenograph of rhabdomyosarcoma cells and osteosarcoma cells, and we were able to see how not only the CAR T cells work, but also when we re-challenge with tumor cells against the mouse, the CAR T cell expands again. So this is a proof of concept that the CAR T cell can expand when they see its target. Well, all of this data, and with the help of CRIS Cancer Foundation in Spain, in Madrid, first of all, we have to build a GMP facility in our hospital. Our hospital is a public hospital, very humble, very big one, but we did not have at that point a GMP facility, so we were able to build a small one GMP facility, only 20 meters square of GMP facility per se. It's a small one, but we have a closed system with a Prodigy. We have a peroxidator. We have everything we need. It has been approved by the Spanish regulatory agency. Now it's the second auditory we have passed, so it is well done. And now we are planning to have a new one in the following year, because we can only produce one CAR T cell per month. This is all the thing that they are doing, but for us, the most important thing is we are very close to the kids. So we can do it in a very, we can take the cells from the donor, we can produce in the GMP facility, and we can go to the best as far as we can. So these are the trial. It's already started, the CAR4SAR trial. We are planning to put IV NKG2D and also locally NKG2D. So this is a two-arm study, just IV and IV intratumoral, both of them. So we have 3 cohorts of those: 1 × 2·7, 2 × 2·7, 3 × 2 × 2·7. And because it's a very difficult trial. I mean, because it's not only pediatric hemato-oncology, it's radiologic interventionists, it's many people working on that. So for example, this is a bone metastasis in a vertebral corp. So you can see the doctor have to identify in a CT scan how the lesion and how she can put the treatment into the tumor. So this is what we are doing in the bone, but also when it's accessible into the patient. So these are some of our patients. So far, we haven't seen any response, because most of these patients have a very, very aggressive disease. So we haven't seen any disease. So these are our data so far. As you can see, we only have seen 3 partial response. I mean, So how difficult is to move from the successful data in the research to the unsuccessful data in the clinical setting. So this is something, it makes us so sad, but we have to move forward and try to understand what is happening. So we are still ongoing with the trial, but we know that it's very difficult to cure this patient. So how can we do making better immunotherapy? So first of all, we have to learn what is happening in this tumor. This is so important to have samples to understand if they are not responding because the CAR T cell is not moving well or it's not working properly, or why it's going on. So at the end, we think we need more persistence. Similar as Percy said in leukemia, persistence of your treatment is a key of the treatment. So as much as we are able to keep on our treatment on the patient, as better. So this is not easy in allogenic setting, and it's not easy in solid tumors. Second, we have to consider that the tumor cells defend about our immune system. There are many inhibitory signals to the immunotherapy. It's what we call the tumor microenvironment. It makes very difficult to the immune system to address. So he tried to defend for our immune system aggression. So we have to try to target not only the tumor cells, we have to target as well the tumor microenvironment. Third, we need to target not only one target, we need to do different approach. When we treating our patient with chemo, we are treating not only with one drug, we are giving 4 or 5 drugs in different cycles. So why cannot do different chemo or CAR T cell with different approach? So maybe what we are planning to design is a cytokine-induced memory NK cell expressing different receptor, or maybe doing some editing to remove some inhibitory signals as NKG2D8. Also, we are working on how to localize as better our treatment. We are trying to put on some nanoparticles to move by a magnetic to move your treatment wherever you want. So this is something to improve infiltration, to give more persistent properties. We are trying to give what we call TRAC, is the next generation of CAR T cells. It's not only express one target or one intracellular domain, just to have the chance to liberate cytokines as well, to improve proliferance. Also, we are doing this cytokine-induced memory like NK cells and combination of treatment. So at the end, immunotherapy in our patient is not the response, it's one further treatment, but we need to combine with chemo, with radio, and with other approaches. So this is my last slide, just to summarize my topic. So sarcoma in kids remain a deadly, lethal disease with very, very little improvement in the last decades. Immune system, immune cells as NK cells are able to recognize not only the tumor cell, but also the initiating tumor cell. This is something that is very, very important. It's so important that chemo cannot recognize these initiating sarcoma cells. So clinical trials ongoing now. We have very good data about feasible. It's something we can do. It's not as expensive as we can think, and it's safety. It's absolutely safety doing in allogenic way, and so we have to try to improve, to know the weakness of the treatment and how can we improve to give them more strength. So we have now multiple ideas to do better immunotherapies, targeting microenvironment, multiple targets, improving the tracking, the homing, the persistence. So hopefully in the future, I can give you better news about our sarcoma patients. So thank you so much anyway. This is all our group that most of the patients, of the young people who is working here, are supporting by CRIS Cancer Foundation. Now we have our dream in Hospital La Paz to develop in the following years a cancer center, as ATGOS is going to have in the following years. So hopefully our department, that is only one of in a big hospital, is becoming now a CRIS Cancer Hospital, a cancer comprehensive kids hospital. Hopefully it's going to have good news in the future. Thank you so much for your attention.